Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you're probably looking at this picture, saying to yourself, that's osteoarthritis. And I'm looking at you with the proud eyes of a father watching his child walk. You're doing me proud. You're doing me proud. We're going to be discussing this and much more in this presentation on joint pathology. This is covered in your book, Medical School Pathology, and Step 1 Review. You can scan the QR code to get to the updated material. Joint pathology is the study of diseases and disorders that affects the joints. This cartoon highlights some of the general anatomy of the joint space, in particular this articular cartilage and bursa of the knee. In this section, we'll focus on osteoarthritis, rheumatoid arthritis, seronegative spondyloarthropathies, such as Ankylosing Spondylitis, Reiter Syndrome, and Psoriatic Arthritis, infectious arthritis, gout, classic, you'll see that for sure, and pseudogout. So what's a joint? Well, the link between two bones is made by joints. In general, there are three types of joints: fibrous, cartilaginous, and synovial. Cranial sutures are solid fibrous joints that are securely attached to provide structural support. Synovial joints have a joint gap that permits motion. And for synovial joints, a joint capsule surrounds the hyaline cartilage that makes up the articular surface of adjacent bones. In order to lubricate synovial joints and promote fluid mobility, the synovium lining of the joint capsule secretes fluid that is high in hyaluronic acid. Here we have a picture showcasing various types of joints, and another picture showcasing a particular type of joint. Note the location of the articular cartilage. Now let's discuss degenerative joint disease, starting with osteoarthritis. Osteoarthritis is due to wear and tear that results in articular cartilage degeneration over time in degenerative joint disease. Take, for example, these pictures here to the right. Note the damaged cartilage from sows, that is. Sow's a cow. But this is highlighting the cartilage erosion and cartilage ulceration and the negative effects on the cartilage. Osteoarthritis. Well, this type of arthritis is the most prevalent in the elderly. Risk factors for osteoarthritis include being up there in age, like 60 years old or older, and obesity because of the excessive strain on the joints. Osteoarthritis is known as oligoarticular because it only affects a few joints. Common sites of osteoarthritis include the knees, the lower lumbar spine, the hips, and the finger joints, in particular the proximal PIP and distal DIP interphalangeal joints. Common symptoms of osteoarthritis include joint stiffness in the morning, joint stiffness that becomes worse throughout the day, and joint stiffness that worsens with activity. Pathologic assessment will show absent or disrupted cartilage on the articular surface of the joint. Hibernation, or eroded cartilage, and osteophytes, the bony outgrowths, are classically seen in osteoarthritis. Fragments of cartilage floating in the joint space are called joint mice. And additionally, osteophyte formation that typically develops in the distal interphalangeal and proximal interphalangeal joints of the fingers. Note the acronyms or eponyms. Now here we have imaging of a patient's hand and finger, showcasing the erosive effects of osteoarthritis. Note the gull wing appearance. And here we have histopathology showcasing osteoarthrosis of a knee joint in an elderly female patient. And here, look at the joint space basically being null. That's why there's bone on bone. Also, note the osteophytes and the narrowing of the joint space. This is subchondral bone density increased as well. And even MRIs can pick up osteoarthritis. Note the characteristic narrowing of the joint space. And here, in a patient's hand, you can see the effects of severe osteoarthritis and osteopenia of the carpal joint and first carpal metacarpal joint. And here's a cartoon indicating key features associated with osteoarthritis. Note the decreased joint space, the worn cartilage, and the exposed bone. And here is secondary osteoarthritis due to an old injury with fracture of an ankle in a patient, an older patient. Yeah. And this is various images showcasing proteoglycans within the cartilage of chondrocytes and early osteoarthritic cartilage and severe damaged osteoarthritic cartilage, respectively, from left to right. Now, rheumatoid arthritis. Rheumatoid arthritis is a chronic, systemic autoimmune condition. Take, for example, this x-ray here. Are you able to recognize the features of rheumatoid arthritis? Rheumatoid arthritis typically affects women above childbearing age. Rheumatoid arthritis is linked to HLA-DR4 and is distinguished by joint involvement. The hallmarks of rheumatoid arthritis include synovitis, pannus formation, and inflammatory granulation tissue. Rheumatoid arthritis may result in joint ankylosis or fusion and cartilage degradation. Note this picture to the right of a hand that was severely affected by rheumatoid arthritis. Now, there are several clinical features that can be seen in rheumatoid arthritis, including morning stiffness that gets better with movement, symmetric involvement of the PIP joints of the fingers, swan neck deformity, wrist or ulnar deviation, pain in the knees, ankles, and elbows, DIP joints that are usually spared, unlike osteoarthritis. And then vague, unspecific, non-specific features such as fevers, weight loss, etc. But make sure you can tell the difference between osteoarthritis. Radiology of rheumatoid arthritis classically shows osteopenia, cartilage loss, and narrowing of the joint space on X-ray. Take, for example, this image here. This is a close-up of bone in rheumatoid arthritis. The Fc component of IgG, a rheumatoid factor, is the target of an IgM autoantibody. Synovial fluid tests of rheumatoid arthritis will show increased neutrophils, increased protein, and decreased glucose. Complications of rheumatoid arthritis include anemia of chronic disease and secondary amyloidosis. And here we have a couple pictures of a patient with arthritis. The one on the further side of the left is very bad, and the image on the right is actually not so bad, not bad at all. Here we have a right stain of macrophages and synovial fluid from a patient that had rheumatoid arthritis. Note the neutrophil granulocytes and the small lymphocytes. And what about seronegative spondyloarthropathies? Well, a lack of rheumatoid factor is one of the characteristics of this group of joint disorders. HLA-B27 involvement and the axial skeleton are typically associated. The sacroiliac joints and spine are affected by Ankylosing Spondylitis, which develops in young adults, most frequently men. Low back pain is one of the symptoms of seronegative spondyloarthropathies. Eventually, the involvement of vertebral bodies appears, causing the vertebrae to fuse together or form a buzzword, bamboo spine. Extra-articular manifestations of ankylosing spondyloarthritis include uveitis, aoritis leading to aortic regurgitation, and Reiter Syndrome. Reiter Syndrome, by the way, also includes the triad of conjunctivitis, urethritis, and arthritis. Reiter Syndrome appears in young individuals, mainly men, weeks after an infection with chlamydia trachomatis. Psoriatic arthritis is seen in 10% of cases of patients with psoriasis. Psoriatic arthritis typically involves axial and peripheral joints, and the most common afflicted DIP joints are those in the hands and feet, which can result in sausage fingers or toes. Psoriatic arthritis is associated with scaly rashes. Now, infectious arthritis. A bacterial infection of the joint space that causes inflammation is infectious arthritis. As you can see here to the right, in this case of septic arthritis from a shoulder presenting as stiffness of the shoulder. Neisseria gonorrhea in young adults, which is the most frequent cause, is one example of a bacterial cause of infectious arthritis. Staphylococcus aureus, the second most prevalent cause of infectious arthritis, is a factor that affects older kids and adults. The knee is the typical affected joint of infectious arthritis, and it typically manifests as a heated joint with restricted range of motion. So make sure you're looking out for this accordingly if you're in a clinical scenario. Infectious arthritis causes an elevated ESR, or erythrocyte sedimentation rate, as well as leukocytosis, which is a raised white blood cell count, and fever. Here we have a picture showing septic arthritis of an ankle in a 3-month-old, and the fluid that was collected from the synovium of a knee from a patient with septic arthritis. And here, a familiar image showcasing well-formed epithelioid granulomas with Langerhans giant cells and necrosis, in this case of infectious arthritis. Now, gout, you will see this for sure. Gout is due to monosodium urate crystal deposition in tissues, particularly the joints, as a result of hyperuricemia. Take a look at this picture here. Make sure you recognize it. This is gout, presenting as slight redness in the metatarsal phalangeal joint of the big toe. Gout is connected to uric acid overproduction or decreased uric acid excretion. Purine metabolism produces uric acid, which the kidney excretes. The most prevalent kind of gout is primary. However, the cause of hyperuricemia is uncertain. Monosodium urate crystals deposit in the joint, triggering an acute inflammatory reaction. Secondary gout is observed in patients with leukemia and myeloproliferative diseases due to increased cell turnover that causes hyperuricemia. Lesch-Nyhan syndrome, which is a X-linked deficiency of hypoxanthine guanine phosphoribosyl transferase, HGPRT, presents with mental retardation, self-mutilation, and gout. Reduced renal excretion of uric acid is a sign of renal insufficiency. Podagra and excruciatingly painful great toe arthritis is the classic manifestation of gout. Risk factors for gout include alcohol consumption and cured meat consumption, like salamis, pepperonis, etc. Gout classically has tophi, which are white, chalky, and form along with fibrosis and a giant cell response. In the soft tissue and joints of people with chronic gout, uric acid crystals can accumulate into aggregates called gouty tophi. Laboratory results of gout typically show hyperuricemia. Urate crystals associated with gout can accumulate in the kidney tubules and may result in renal failure, i.e., urate nephropathy. Histology of gout shows yellow needle-shaped crystals with negative birefringence under polarized light. Gout treatments include lifestyle modification, NSAIDs, right? Non-steroidal anti-inflammatory drugs, colchicine, and allopurinol. Here we have a picture of gout. Which foot has gout? You need to be able to recognize that. The one on the left, right? Which is the patient's left. We have gout in the big toe of the left compared to the healthy right foot. Now, which of this patient's feet have gout? Yeah, gout, complicated by ruptured tophi, the exudate of which tested positive for uric acid crystals. It's okay. And another foot affected by gout, this time in the ankle, you can see there, and maybe even the third digit there. More gout, this time in the ear. Yes, gout can occur in the ear. And this is light microscopy of a touch preparation of a gout tophus, showing the classic needle-shaped crystals, right? Needle-shaped crystals of gout. And here we have a patient experiencing gout in many different areas. Now, pseudo-gout. Pseudo-gout results from calcium pyrophosphate dihydrate deposition, or CPPD deposition. Take a look at this image here to the right. Make sure you recognize it. This is pseudo-gout. The microscopy here with polarized light of the tissue showcases these classic crystals for pseudo-gout. Under polarized light, pseudo-gout has these rhomboid, squarish, sort of rectangular crystals. Normal gout would be needle-like. But pseudo-gout, clinically, is similar to gout. In pseudo-gout, the synovial fluid exhibits rhomboid-shaped crystals with weakly positive birefringence under polarized light. And with that, you completed another presentation. I'm so proud of you. Like, seriously, really? You got this. You're studying in your book. You have the updated material at the website. You're cranking through lectures. You're up late. You're doing your work. You're waking up early. You're doing your work. You got this. You're going to succeed. I believe in you. Everyone's rooting for you. Keep up the good work. See you on the other side.